it's regarding customized cross-linking, and by this way I go through quickly through some basics on the cross-linking, on the elasticity and plasticity, and you all know the big difference between the elasticity and the way it changes and then go back to the original state, and the plasticity where you have a permanent change in the form, as you can see there in the Adidas. And also you can think about customization in cross-linking, what we have done so far. First of all, we changed riboflavin from the dextran into the HPMC, and this make a great advantage in the cross-linking because we didn't have this shrinkage, this loss of thickness during the cross-linking, the effect that usually we have with dextran. Customization on the way we change the shape of the cornea at the same time as doing the cross-linking. In the standard, we just didn't change anything on the shape of the cornea. Then it was the Athens protocol by John Kanellopoulos, and a few years later, the Cretan protocol by using topographic PTK or PRK or just PTK by George Kimionis, and the femto cross-linking done by me and John Kanellopoulos as well, just doing femtosecond first and then injecting cross-linking inside the cornea. And the last customization, the most important, I think, is the curve, which is the attempt to customize and do the cross-linking exactly where you need to do. So with the standard procedures, we have an improvement of 1 or 2 diopters, and by adding the PRK, we were just taking out some part of the tissue, usually 50, but I can see some cases with 60 or 70 microns. Regularized slightly the cornea, but still you can see that there is quite a loss of thickness in the same area. The results were excellent, as you can see from the original paper by John Kanellopoulos, and here is one of our patients back to 2008, where you can see that you can regularize quite a lot the coma effect that you can get from the cornea. And here again our patients, usually because you do a kind of hyperopic treatment on the opposite side from the cone, and this can regularize and create a kind of central cone with the astigmatic component. But all that comes with the cost of losing tissue, and this is something that we really didn't want to do because we don't know the long-term effect of that. And this is just to imply how we lose this tissue. So why don't we do a customized cross-linking? Basically by localizing a more intensive treatment in the center of the cone, and then a less intensive second and third zone in the same area. By that thing, you will just decrease the curvature without losing too much of thickness or any thickness, which is very important for these ectatic corneas. And the only way to do that is by having a special machine which can, in a way, take out the pentacam images and then try to translate these images into the cross-linking at these particular areas that we want to do it. And here are some very early results that we have regarding epi-on or epi-off procedures. And by epi-off, I would like to make sure that we use a specialized mask. We are only one of the 3 or 4 centers in the world that we use a specialized oxygen mask, so that to increase the oxygen consumption at the end, during the cross-linking procedure. That's why you will see in most of the cases the demarcation line, which is one, or at least the most important indication of how deep you can go with the cross-linking at this moment. So you can see demarcation lines like this. At the central area, we can go as back as 360 microns, and in the periphery only 136. That is with an epi-off procedure, but with the epi-on, with epithelial-on, we can still go about 2/3 of the cornea and have this quite dramatic effect on the area of the cone, and leaving the periphery with less cross-linking. And we have seen that on and on in all of our so far 16 cases that we have. On the other hand, we do see the reduction of the Kmax in the same stage. This is another case that I will show you with customized cross-linking. And in this particular case, we are centering the procedure on the thinnest point, and or we can combine customized cross-linking with PRK when we want to have an augmented result. In this case, we were centering the area of the high intensity in the posterior surface, in the posterior elevation. We still sort of performing more cases, and we're setting up a new trial on Epion with customization both on the intensity of the UV light and on the expansion of the area that we're going to centralize our treatment. But we do believe that the best way is to centralize it on the thinnest area on the pachymetry map instead of the posterior elevation. We have a lot to think about because there is still some missing technology, and we're waiting to see the Bruen technology showing us the way ahead on extending, on having maps with biomechanical properties of these corneas, and if possible, then to customize our technique according to the Bruen maps and not on the Pentacam maps. But so far, we are doing it on Pentacam maps. Thank you very much for your attention.